Cynda, I'm such a longtime admirer of your work, and gratefully, you've become a mentor of mine through our work together with the National Academy of Medicine, their task force on clinician well-being, as well as at the Institute for Health. You are still faculty. So thank you so much for coming along with me to ABIM Foundation and for sharing your wisdom with us today. For folks who are new to your work, can you share a little bit about your journey and what inspired you to pursue your career in nursing and ethics and trust and moral resilience and education?
Yeah. Well, it's really a pleasure always to be with you, Jess, and to have a chance to talk about topics that I know all of us are sort of struggling with right now. You asked about my journey. Well, it's not been a straight line or anything that I actually planned very much. It was a series of saying yes to many things. I started out as a nurse in the pediatric ICU, and in that role, obviously, it was a time where technology was advancing and there were lots of ethical issues. And I found myself often involved in trying to help families make hard decisions. And that led me to the next thing I did, which was a clinical nurse specialist in pediatric cardiology and thoracic surgery, and then later in neonatology and general surgery. And that was the place where I really was in the midst of lots of ethical questions. And I found myself really drawn to that space, I think in part because I never really been afraid of the messiness. I kind of find myself drawn there for some reason, and pursued further education. I got my doctorate at Catholic University and did all my ethics work at Georgetown. And I've been doing clinical ethics consultation now for decades, still co-chair the hospital ethics committee here at Johns Hopkins. And all of those elements, I think, about our values really are part of what has been the fuel for my work, trying to understand, what happens when we feel our values have breached in some way, and how our integrity is so vital for our ability to do the right thing, but also to serve the people we're called to serve. And so the idea of trust, is part of that sort of landscape. And so there's just been many, many aspects that I've had the wonderful privilege of trying to explore and bring voice to along the way.
That's a perfect segue into where I'd like to start, which is actually around that issue of moral suffering. We know the pandemic alone was not the sole cause of workforce moral suffering, but it did exacerbate it. And this left many feeling betrayed by their leaders, their organizations, and even society. We know there's also profound implications for individual well-being, overall workplace culture. So can you talk to us a little bit about what moral distress, injury, or conversely resilience, what they are, and what do they have to do with trust?
Well, all of these concepts are really very much synergistic with each other. So part of the early work that I was engaged with came out of my own clinical experience of not being able to reconcile what I was doing in terms of caring for children that had some really serious injuries and damage to their brains, and feeling like I was doing something harmful, that I was actually causing more harm than good. And it's that experience that we've come to understand as moral distress, is where there's really a gap between what we think we ought to do and what we're actually doing, and our ability to do what we think is right is constrained in some way. Mm-hmm. And so that has, in our work, we think about moral suffering as a continuum. It sort of starts with this idea of moral stress, where we recognize there's values that are in conflict. to moral distress. And then what we've come to understand is a much more corrosive form of moral suffering, moral injury. And that particular type of moral suffering became much more prominent during the pandemic. And it's distinguished from moral distress, I think, in ways that it's certainly psychological distress that arises from either our actions or our inactions that somehow violate our moral code, those values that are just fundamental to who we are. It can be collective, it can be individual. It often occurs in very high stakes situations. But often what we see, and most of what we understand about this concept is from the military, it's in response to really severe and unmitigated betrayals or transgressions. And what's different, I think, about moral injury is it really results in a kind of dismantling of our moral identity, our sense of worthiness as a person, our moral fiber. And so people describe it as a kind of soul wound, you know, that I don't know who I am anymore. And so that's the one part of the equation. And 7 or 8 years ago, I kept saying, well, what else is possible? Are we just going to be stuck in this distress and there's no path forward? And that was the point at which I began to explore alternatives and sort of settled on the concept of moral resilience, which we've developed conceptually and empirically, that really points to our ability to preserve or restore our integrity in response to all these different types of moral adversity. Now, the important thing about moral resilience, it's not about enabling us to tolerate unacceptable things. It's actually focused on restoring our capacity to choose, our agency, so that we don't feel helpless and victimized anymore, but rather that we feel that we can be whole, even when we're in the midst of these really challenging situations.
Reframing it from an injury or a betrayal to one of activation and agency. But that betrayal is a big word, and it does have everything to do with trust and breaking of trust. And I'm curious if you have how leaders should manage that when they're opening up a conversation about the topic, because it could be a scary one to broach.
Yeah, it can. And, you know, to frame that a little bit from the COVID pandemic, we did research, and in one of our studies that was almost 600 clinicians, we looked at people who had moral injury symptom scores that were clinically significant, and those individuals created comments about what was it that was not captured by the questions we asked. The core theme there was broken trust. And it was broken trust around communication and transparency and expectations and, you know, many factors. We saw the same thing in a workforce survey we did in Maryland of almost 2,000 nurses. And we asked them, you know, about this idea of betrayal. And almost 60% of them agreed that they had been betrayed by institutional leaders who they once trusted.
Yeah.
Almost half said they felt they were betrayed by others outside of the healthcare profession. So betrayal is a big word. And in a way, you know, it's very charged. And yet it's a part of being a human. We will betray one another personally and professionally, but it causes us pain. And when we feel that, you know, we have been betrayed, that trust has been violated, it often causes us to question our worth, our principles, our values, our own sense of belonging. And at the same time, because it is part of being a human, it's an opportunity for growth as well. So if you're a leader, part of it is to examine your own relationship to the idea of betrayal. And what tends to happen is that under pressure, I think a lot of times we rationalize or defend or intellectualize the situation, when in fact, when people talk about betrayal, what they really want is to be heard. They want to be understood. They want to feel supported. And so the first thing I think leaders can do is to listen without being defensive, to acknowledge the feelings, that these are feelings that are predictable when we feel our values have been violated. Anger, resentment, frustration are normal responses to those kinds of situations. So I think it's also engaging and not turning away from that hard space, but actually really leaning in.
Yeah. Yeah. And before I get more into the behaviors that we can use to rebuild trust, I want to know, why does it matter? You know, does it matter? One example that was cited a lot during the pandemic, just to make this concrete for folks, was when we were still social distancing, we weren't allowing family members to be with their loved ones who were dying. And collectively, that was harm. That was harm. So I can imagine at aggregate that had some effect. Had there been links to turnover or burnout or safety?
Yeah, I think that example is a really prominent one in terms of limiting family access. Felt like such a violation of a core value of what it means to be a good clinician, you know, that we involve the people who we are taking care of. And it's interesting, Jess, when you think about what happens when trust is low. Well, it depletes our energy. Communication is often closed off and very guarded. And if you think about the crisis we were in, people were in lockdown themselves, you know, not to mention in their lives. And, you know, the quality of our work really starts to suffer because we think, you know, am I in the right position? Is this place the place where I should work? Can I keep this up? You know, so we start doubting ourselves and our ability to do what we've been trained to do. And what also happens is there can be this cascade of response where we think we don't have any choice. And that leads us to be kind of locked into a feeling of bitterness and frustration, anger and resentment, you know, with it, that is really hard to overcome. And it may kind of take us into a victimized place. Whereas on the other hand, you know, if we are able to really step into the breach of trust and restore our connection with each other and to ourselves, then we have the potential to, you know, really enable our ability to stay true to ourselves and to resource ourselves, and maybe even to grieve what we've lost in the midst of all of that.
So pulling on that thread a little bit, what are some of those specific behaviors that we can use to rebuild trust?
Everything I've learned about the behaviors, I've learned from the Reynas, Dennis and Michelle Reyna, who have created a model for trust building that's been used in lots of different kinds of settings, some in healthcare, but often, you know, in all kinds of organizations outside. And what their work over many decades has sort of culminated in is what they call the 3 C's, the dimensions of trust. And what they find in their research is that 90% of cases when people compromise trust, they aren't even aware that they're contributing to it. And often those breaches of trust are small, they're subtle, and unintentional. And so part of this work is to help us focus on the behaviors so that we can begin to realize where trust is being built, where it's being broken. And the behaviors are really organized around the idea of our individual and collective capacity for trust. The more that our capacity for trust is expanded, the more likely that we will be able to manifest these kinds of behaviors. And so they organize it in terms of these 3 C's: trust of capability, trust of character, and trust of communication. And you'll see here underneath each of these are some specific behaviors. So we used this model in doing some of our research. And what we found very clearly was the things that were breaking trust. If you look at, for example, trust of character, managing expectations during the pandemic. So what did we expect of ourselves? What did the public expect of us? What did leaders expect? What did the people who were delivering care expect? And were those congruent or not? Well, no, they weren't. Boundaries, for example, in one of our studies with nurse executives, they said we were expected to be there all the time and other people were not. So this inequity in terms of expectations. How we delegated, who was expected to take risk. If you think about, nurses, there was a point in the pandemic where there was not enough PPE and decisions were made that nurses were going to go into the patient rooms who were infected with COVID while everyone else stood outside and looked in. So that's an example of, well, how does that actually, those behaviors, how do they build or break trust? Keeping our agreements. So that's another example where many people at the front lines felt that there was an implicit promise made by their organization that they would have the resources to keep them safe. When it wasn't there, it felt like a betrayal. So you can go on with each of these, and what we find consistently, and this was true in a small study we did many years ago, is the place we tend to be most vulnerable is around trust of communication. How we share information, what information we share, how we tell the truth, the whole truth, nothing but the truth, or part of the truth. What happens when mistakes are made? How we give feedback. And one of the really important ones is, how we maintain confidentiality. How do we, do we gossip? How do we engage together? So for me, the behaviors have been really helpful to take this big concept of trust, which is complex itself, and then trying to find a way to engage in a practical way, how we might begin to notice those patterns in ourselves and others and in our organizations, and then how we could potentially rebuild it when it's broken.
I love how concrete that is, Cynda. One example, one of our colleagues, Amar Shah from East London Health Foundation Trust, shared with me is switching from, if your tendency is to gossip, using positive gossip as actually a builder of trust. So if you're likely to say, Dave did such an awesome job, I just have to share. He just, got off this presentation and really nailed it. How that can actually foster a culture where you're feeling like we're respecting one another and we can show up authentically. Thank you for getting specific here.
It's a great example, Jeff.
Yeah.
Talk about, so the reason we gossip is connection. So, your point is we can modify that in a way that actually doesn't break trust, which is really, really important.
So getting a little bit deeper, there's a bit of this that has to do with trust builders and trust destroyers. And I'm wondering if you can give us a little more on that.
Yeah. If you really look at, what was happening before COVID, I mean, COVID just made everything more clear and more intense. But for example, if you look at this trust of capability area, one of the things we've seen in some of our research is, and a lot of my research involves nurses, so, forgive me for that or not. But one of the things that happened was decisions were made without involving them in making the plan for how they were going to reallocate patients, or how they were going to, cross train from one unit to the next. That lack of asking people and saying, you know this work the best, help us figure out the plan, rather than giving them the plan and saying, well, now implement it.
Yeah.
That's a place where trust got broken, because people want to be involved in the decisions that affect their work and their lives. And how we do that matters. Another example, and I was just talking with somebody a few minutes ago, we survey people to death. We get all this information, and what do we do with it? So having clear expectations, and this is where communication comes in. What will you do with the information that you've collected? How can you feed it back in a way that helps people know they've been heard? How do you then demonstrate that I've acted on what I learned, and here's how I used it in my decision making? That's around trust of character. So I think there's just so many ways that we can lean into this, not in trying to. One of the things I really value about how the RAINAs use the data they collect with their instruments is the way that they feed that back, is focused on something I know you're familiar with, Jess, of, you start with what's working, and how do we amplify what's already here to address the places where we're breaking trust, because those will be there as well. And even that is how we begin to create a culture where we are all aware of the many places where trust is being built and broken.
That's such an important point, especially because of the one you mentioned, where people are really feeling over-surveyed. So that is kind of lends itself to this question of, how are we going to know if these trust building practices are working, and how do we measure it?
Well, that's a hard one, right, Jess? Because it's a complex, it's a concept that has many dimensions to it. The RAINAs have developed their own measurement, of leadership trust, team trust, organizational trust. But I think on a really practical level, I think that it starts with each of us, how we are together. And in our work, we call that our relational integrity. The way in which we come together in a way that honors all of us, that none of us are diminished in any way. And so, a lot of times I think we want to, we're going to change the whole system. Well, that's going to take a long time. So to me, it's how do we begin to consciously and intentionally look at how we are engaging with each other, because we also know that when that trust is present, it's going to resonate in our nervous system, just like it resonates when trust is broken in our nervous system. So it's a kind of collective resonance when we can it's all boats rise, really. And so then we can start to see, for example, what would it be like if we changed our handoff process, where instead of sharing information that we find interesting about the patient, that we actually focus in on their strengths, that we tell a story that is not one that is reflective of our biases, but rather a story that is more true to who they are, or how we might talk about each other. That begins that ripple effect of finding those places where could we start with this, and see what happens as it begins to grow in an organization.
You're painting a picture of what it's like to slow down and check in and pay attention to some internal signals of how this is working or not working in your day and the effect that that could have collectively if we're all doing this with intentionality. But there are some challenges to this, demand being what it is, volume pressures being what they are. So there are definite challenges to maintaining a trusting environment. Do you have any suggestions for kind of cultivating a sustainable approach to this work for either an individual or an organization?
Well, I think, first of all, starting with ourselves, but also how do we make this not an add-on? How do we make it part of our core work? That everything that we do is filtered through the frame of, is this building or breaking trust in how we're making decisions, how we're communicating, how we're involving people. It's almost like you need a checklist. I hate that idea, but in a way of sort of saying, we're going to roll out this new thing. Where are the places where trust has been built or broken already? And how can we, in a more proactive way, consider where the places of vulnerability might be? And how do we plan for those as opposed to being surprised later? Because what we know for sure is that rebuilding trust takes a lot more effort than avoiding breaking trust in the first place.
Yeah, it does a lot more harm. And what I've heard you say too is not only just identifying where we need to start the work, but when we've encountered this before, what have we done well? So you're also using an asset-based approach to the solutions. So this has been incredibly helpful. When we asked folks to register for this event, they submitted a whole host of questions for you. So I'm hoping I can dive into some of those now, and then I'll turn it to Jamie to raise up what she's seeing in the chat. The first is, how can professionals in healthcare connect with their communities in non-expert ways to promote trust in public health, science, and medicine?
A great question. And I kind of go back to, you got to show up as a human and not as your identity and not as your expertise, but really just human to human, to me, is the best way to build trust. And I've seen that so many times in ethics consultation when, we've been at odds with one another. We don't agree on the goals of care. And sometimes it's really just connecting as a human to say, this is a really hard situation that we're in, and we all care a lot, and we're trying to do the best we can. And tell me about you. Tell me what matters to you. And then listen.
I love that. What matters to you? It's such a simple question, but it's a different frame from what's the matter. The second question is sort of on the other side of that relationship when you've been harmed. So the question is, I understand you need to build trust with others to improve patient care, but you also need to have trust in the institutions where you're providing that care. What do you do when you've lost trust in the institution that employs you?
Well, we're certainly hearing a lot of that. And, I think there's many ways to answer that question. And let me try to answer it this way. I think that there's opportunities in that process of discernment. And you mentioned slowing down. I think we have been through a crisis. We are not even, I don't think, we don't know yet what the consequences actually are of this post-COVID world. And at the same time, I think we have to engage in new conversations with ourselves, but also with our organizations. The patterns in the organization that are breaking trust. How have we acknowledged and detected those? How have they been communicated? What recommendations have been made to solve them? So there's that piece of the equation. I think that organizations have a responsibility to create mechanisms to be aware of where trust is being broken, and to have surveillance and action plans for how to address those. That's how trust gets rebuilt. If you're in that situation where you feel that you have exerted sufficient effort, and for me, integrity requires us to be part of identifying those problems. It doesn't mean that we have to solve them, but it is part of our job to bring voice to them and to engage in trying to find solutions within a set of boundaries. We're not talking about, forever, ever, if nothing changes. I'm not suggesting that we just, put our heads down and stay in those situations. But I do think there's a process of discernment. And everybody will need to find their own, sort of path through that. But I think there are a number of questions we ought to ask ourselves. And, what are those patterns? What are the things? I think of Jess, of, the rock in your shoe, the pebble in your shoe that is causing you to feel betrayed. Can you name that? Can you say what that is? And can you link it to why it matters to you? So I'll give you an example. Everybody's talking about staffing. Why does staffing matter? It's not numbers alone. The reason that staffing is important to us is because when we do not have the resources that are necessary to provide care that is safe and reflects the quality that we have committed to, it then leaves us feeling as if we might be causing more harm than good. But it's important to peel that back so the conversation is not just numbers. It's the why it matters. And being able to, have those conversations. I think it's important that we exert some effort in that conversation, to be willing to be part of solutions. But at the point where you realize that this is a toxic situation for me, it is degrading my health, my well-being, my entire life, that's probably a situation where you need to remove yourself from that kind of environment. And I'm not suggesting everybody leave, but I am suggesting that we very intentionally assess and to be part of the solution to the extent that we can. And hopefully by doing that, individually and collectively, we will engage our organizations in a different conversation about why this matters.
Thank you for that. A complicated and heavy one to tackle, but I think you've given us a roadmap for how to do it with integrity for ourselves and respect for the work we love, and appreciate that. The second, it's sort of a duplicate of what I'm seeing in the chat, so I'm going to try to lump them together, which has to do with so Randy, your question here. Marginalized communities, do you think trust has diminished most severely in those communities? And there's a question here about rural communities in particular, where trust in institutions generally, where schools, elected officials, as well as in healthcare, feels like it's at a low point.
Yeah, I think we are at a low point. There's no question about that. And I think there is no quick fix. And it really does kind of go back to how are we with our neighbors? How are we with each other? And where can we actually demonstrate a different way of being? And, one of the things I've learned about integrity is your integrity is going to be influenced by what others do, but it is fundamentally yours to decide. So whatever's happening around us, we can choose how we are going to be in that moment. And you can say, well, that's not going to change anything. How do you know that? How do you know that you might be the one person who listened? You might be the one person who made eye contact. You might be the one person who acknowledged another human being. You don't know. So I think we have to do that. And we also have to collectively say, we are going to stand together to make big change. And I don't know the answer to that. I just know that we have to do both in order to, to make any difference at all. And the other part of that, I think it's very easy to feel overwhelmed by the enormity of this problem. None of us can solve this on our own. None of us. But together, I think we actually could begin to shift things in the direction that we want to live in. And I'm hopeful for that.
Randy, I see you're on video and I've asked you to unmute. I'm wondering if that adequately answered your question or if you have any follow-up for Cynda.
Cynda, my second question was about this shift that we're all experiencing to health technology and AI. And I've been working in the marginalized communities in Massachusetts for about the last 2 decades. And so I've become really familiar with the people in these communities who don't have access to computers during the day. Many of them have 2 jobs. The libraries close at 6 and they've just gotten home. The healthcare centers close at 6 and they've just gotten home. Is this current shift to more and more health technology just going to leave the 30% of our country in those communities behind? And what do we do about that? I mean, it seems to me we have to be looking at smartphones. They all have smartphones and they all text. I'm very concerned about these people.
Well, I hear you. And of course, this is another example of the inequality of access in, so many ways that impact people's lives and their health. So I think your instinct is a really important one about how do we balance that that table a little bit better so that we create the resources for people who don't have the resources you and I have to be able to have excuse me, at least a basic mechanism for access. So, some of that is really political action. It is collective action for people who are engaged in those communities to really harness their collective commitment to focus on an issue that, really might make a huge difference if we were just to do one thing. I think part of our problem is we're so scattered. Right? Like we've got a million ideas and they're, we could be scattered very quickly. But I guess I wonder, how you might be able to really focus that in and show how that investment really would make a difference in lots of areas of people's lives. I don't know if I'm not an expert in that piece, but.
Thank you, Randy. The second kind of group of questions kind of fall into this category of what I would call trust as a determinant of health. And so the questions here have to do with best practices for rebuilding trust with older Americans in particular, and between older Americans and their families and institutional care providers. That's the specific questions.
So I would say that you could very easily use these 3 dimensions of trust to start. So, for example, I know that people who come for care, whatever age they are, have expectations about what will happen when they come to us. And a lot of times the systems break the trust before they ever see a provider, because you can't get scheduled, you can't talk to a human, you can't, you know, on and on and on, you can't navigate through even the building. And so, you know, it's also taking some of these behaviors around trust of character, how we set expectations, how we have boundaries, how we communicate, I think is really, really important. What are our means of communication? So Randy's comment, if we're building a system that the people we're trying to serve don't have the mechanism to receive it, it's not going to work. So it's back to, we got to ask, go to trust of capability. Ask people and listen to them, because I think as clinicians, sometimes we get so caught up in our identity as being the problem solver that we forget that the people we're trying to serve probably know the answers. And it's a relief to know you don't have to know them all. You just have to ask them and they'll probably tell us. So I think these very same behaviors could be the roadmap for it. Just thinking about where some of those behaviors, you know, what do we know about where trust may be vulnerable? And maybe we could intensify or improve even one area of each of those three spheres, would probably move us a little closer. At least that's my hope.
Probably. And I think that your answer just now kind of answers this question, but the lens of disinformation and misinformation. So the question has to do with, it's a longer question, but the general public and the spread of misinformation and this breakdown in trust. So do you have any thoughts about effectively navigating this?
Gosh, I wish I had the magic bullet on this one. I think what it's pointed out is how truth is defined by people's values, but it's also defined by their biases and their assumptions. And I guess the one thing I would say about this, and something I learned before COVID and trying to engage people of different political orientations to come together to actually know each other in a different way. What we found over the course of a weekend was that we had a lot more in common than we had that was in opposition to each other. We had different ideas about how to get to that end result. And so my instinct would be to try to understand where that framing is coming from. What are to make more explicit, what are those assumptions? And, you know, unfortunately, a lot of that is fueled by our communication systems and the media. And I think we need to explore what the ethical framework of communication writ large ought to be, and how we might be able to, you know, begin to find a way forward. I suspect we're never going to be able to completely overcome it now. But I think one thing we could do as communicators is to make explicit what the assumptions are that we are basing our information on, and to make that open and transparent, and to also acknowledge the limits of what we know and what we don't know. Because what got us into trouble in COVID is claiming certainty when we didn't necessarily have it. And I think that's a trap when we think that trying to suggest that we're certain makes people feel more secure. It doesn't always, especially when the information evolves and we learn something else.
So appreciate that, Cynda. And that point about uncertainty is why our foundation put out a call for proposals on the topic of navigating uncertainty and teaching about uncertainty, because there's a skill set around it and is an important part of building trust. Thank you for that. So the last question I have here is, what advice do you have for aspiring nurses and healthcare professionals who are passionate about promoting ethical practice and resilience in their careers?
Well, we need a lot more of you. So I would say this, depending on where you are in your career, start with where you are. Get yourself involved, either in your organization, in your ethics committee, if there is one. If not, be the agitator to create one. Also, involvement in our professional organizations. I have to tell you, that is the place where I had the greatest support, was as part of the American Association of Critical Care Nurses. I was part of their ethics committee many years ago. We created all kinds of resources along the way. So I think you start where you are. You can be part of changing that practice based on how you practice, how you communicate, how you show up. And, we think, oh, that's not going to matter. It does matter. It matters every single day, how you practice. And then what are the opportunities beyond that? Yes, absolutely. We need lots of people who will care about this territory. And from my point of view, the more the better.
I love that, Cynda. I shouldn't be surprised. It starts with us, which is a key takeaway for me of our time together today. I can't thank you enough for this. It's been valuable. I promised we would get you off early because I know you're going to speak again with another cohort right after this. So thank you for being with us and sharing your wisdom with us today.
Thank you, Jess, and thank all my colleagues who showed up today. I think we all want to be whole, and we all want to be able to work in environments where we can be whole, where we can serve to the best of our capacity. And it's not a one-off. It is a lifelong process, and it requires all of us. We are the ones we've been waiting for. So let's do it. There's no time like the present.
Beautiful. Thank you, Cynda. Thank you, everyone, for being here.